Okay, so here we have the peptic ulcer disease. Very common. Okay, peptic ulcer disease will give you like two sorts of things. You have the gastric ulcer or the duodenal ulcers. So if you let's talk about each one of them. Pain. Wait. Pain. Pain can be greater, G for gastric, greater with meals. So when you have a pain when you eat, you're not going to eat. It's going to give you weight loss. Duodenal ulcer, D, this is very important, okay? D for duodenal ulcer, D for decreases with meals. Well, when you eat, you don't have pain. I mean, I'll be eating all day. So weight gain. Okay. Let's talk about H. pylori infection in them. 70% of the cases of the gastric ulcers is H. pylori, while the 90% of infections, 90% of duodenal ulcers is H. pylori. So who got the more? This guy. H. pylori infection, duodenal ulcer, 90%. Great. Mechanism. Well, this is decreased mucosal protection against the gastric acid. So you have decreased the protection. Now, when the gastric acid gets secreted, you're destroying more because you don't have any protection. Here, either you're doing the same action or you're increasing the gastric acids. Okay. What are the other causes? So other causes, remember we just said H. pylori is 70%. So what about the rest of 30%? Doing the math, right? So 30% here is the NSAIDs. So if we were to do 90% there, so who else is getting that 10%? That's the Zollinger-Ellison syndrome. Okay. A risk of carcinoma. There is in gastric ulcers, you have increase in the risk of gastric carcinoma. So that's why you have to biopsy the margins to rule out the malignancy. But here, because it's a small intestine, you rarely have any carcinoma of small intestine. So you don't need to even biopsy. Not routinely biopsy is generally benign because it's a small intestine, right? It's a small intestine. So that's pretty much what we have for these peptic ulcers. Talking about this H. pylori and how the mechanism works, like what is it doing, right? We just talked about how it sits on it and releases proteases and ureases. But what is the actual thing? What is it doing? So this H. pylori, it colonizes the antrum, as we said. It colonizes the antrum. Okay. In the antrum, if you remember, we have the D cells. The D cells are the somatostatins. Somatostatin cells. It destroys them. So leading to decrease in somatostatin. So when the somatostatin is decreased, you have increase in the gastrin. Remember, the somatostatin was in the blanket of all the things. So when you have decreased that blanket, which was inhibiting all hormones, now the gastrin goes high. When the gastrin now goes high, it's going to stimulate those parietal cells and leads to hydrogen secretion in way too much form, right? And that hydrogen, a lot of that hydrogen is going to come down this path and will give you 90% of the cases will give you duodenal ulcers. 70% is going to give you gastric ulcers as well. Duodenum cannot neutralize that a lot of acid, so you get the duodenal ulcers. Okay, that's the first thing it's doing. But now let's talk about when it goes to the body, right? That's the antrum we just talked about. But it's gonna eventually it's gonna go to the body of the body of the stomach too, right? So when it goes to the body of the stomach, it leads to. So let me just draw here. It goes to the body of the stomach, that H. pylori. When it goes to the body of the stomach, it causes, at this stage, it causes direct mucosal damage. So when you have a direct mucosal damage, and this is when you have a direct damage here, the ulcer is going to form, and what's the location? It's still the stomach. So you call it gastric ulcer. Here you go, gastric ulcer. So if you now, let's look at the first aid, what they have mentioned. So they only mentioned sentences. The whole story you gotta know yourself. So here, the mechanism here is the decreased mucosal protection. By direct damaging this, you're decreasing the mucosal protection. But on the other hand, duodenal ulcer, you are decreasing mucosal protection, or you're also increasing the gastric acid secretion. How? By this pathway. That's all H. pylori. Okay, now let's talk about this Zollinger-Ellison syndrome. So the Zollinger-Ellison syndrome, if you see any beyond the duodenal bulb, any ulcer, then you gotta think about Zollinger-Ellison syndrome. Okay. This also causes malabsorption and diarrhea. Okay, what else? One ideal point here is that duodenal ulcers are never malignant. That's why you're not biopsying it. They're never malignant. Okay, so let me erase this and have another chat. Okay. So yeah, that's biopsy. Yeah, we are done here. So now let's talk about this. We had the ulcer. What are the complications to that? That ulcer gave us complication. One thing is hemorrhage. Second thing can obstruct, and third thing can perforate. Okay. So here's the complications. Okay, ulcer complications. Sorry about that disturbance, guys. Here are the ulcer complications. First thing is the hemorrhage. How you have a hemorrhage? Well, you have the gastric, duodenal, posterior greater than anterior. Most common complication: ruptured gastric ulcers or lesser curvature of the stomach, bleeding from the left. So this is very important, guys. Let me explain this, what I'm saying here. So if you have the gastric ulcer, and that gastric ulcer is on the lesser curvature of the stomach, which is going to be here, let's say this place here, lesser curvature, you have, if you get the perforation or hemorrhage, or if you perforate this area here, you are gonna mess up your left gastric artery here. So if you rupture the gastric ulcer on the lesser curvature of the stomach, you are gonna get the bleed from the left gastric artery. Got it? Now same thing. If you have a gastric ulcer on the posterior side, remember that posterior to the stomach there's a splenic artery which is running. So if you rupture that posterior ulcer, that's going to give you bleeding from splenic artery. Okay, that's all about the gastric ulcers. But they're saying, that's all for the gastric. Now let's talk about the duodenal ulcer. Duodenal ulcer, they're saying posterior duodenal ulcers are more greater than the anterior ulcers. Okay. An ulcer on the posterior wall of the duodenum leads to bleeding from the which artery? Gastroduodenal artery. So here's the duodenum. Let's just make it here. So if it is on the posterior side, you are messing up your gastroduodenal artery. Right? And that can also give you, because it's the posterior of the duodenum, so you also have the pancreas, which is coming right here. So it can also cause you pancreatitis. Okay. Now, obstructions. If you have an ulcer as a complication, you can obstruct which things. You can either obstruct in the duodenal ulcer, you can obstruct the duodenum, or in the gastric ulcer, you can obstruct the pyloric channel. Perforation. Perforate, again, same thing which we already talked about. Perforation in the duodenum, anterior is greater than the posterior. So if you were to perforate duodenum anteriorly, what's going to happen? Anterior duodenal ulcer can perforate into anterior abdominal cavity, potentially leading to pneumo. That air is going to go into the peritoneum, causing pneumoperitoneum. Right? So when you have a pneumoperitoneum, you see free air. Look at this picture. You have the free air under the diaphragm, pneumoperitoneum. And what is that? If you look here, you see this white structure is the diaphragm. It is the actual diaphragm. Normally, you should not see a thing underneath that. So this black, all of these, this black and all of this black, look, this crescent shape, that's the diaphragm. Normally, you're not going to see anything under that. But here in this case, we have the air, pneumoperitoneum, air in the peritoneum. So we see air under the diaphragm. That's the, do see this thing? But that's the free air under the diaphragm, which with referred pain, remember we did that in the anatomy lecture, that the Keher sign, whenever we have the blood, the air, anything that irritates the peritoneum, you're irritating the phrenic nerve. That's going to give you a referred pain to the shoulder via the irritation of phrenic nerve. So see, the concepts repeat. So all you got to do is grasp it one time and keep holding that. Okay, let's talk about now is the acute gastrointestinal bleeding. You're going to get a bleed. Okay, acute bleeding, they're saying. So you have an upper GI bleed and a lower GI bleed. Upper GI bleed originates, how do we know? The thing is, what's the anatomical mark? We can say, hey, if it is after this, it's going to be upper, after that is lower. And that is your ligament of teres or treads. Okay. Ligament of treads. They should have, okay, here's the ligament of treads. So after this point, before this point, whatever you have, that's going to give you an upper GI bleed. After this point, you're going to call it a lower GI bleed. Okay. So the second name is the sensory ligament of the duodenum. Usually presents with the hematemesis. So again, one more thing. Hematemesis or melena. Okay, associated with peptic ulcer disease, variceal hemorrhage. On the other hand, the lower GI bleed originates distal to ligament of treads. Usually presents with hematochezia, associated with IBD, diverticulosis, angiodysplasia, hemorrhoids, anal fissure cancer